or in the field. Acute primary angle closure is intraocular pressure more than 21 mercury with two of these symptoms as tabled here: pain, nausea, antecedent history of intermittent visual, blur or halos. And one of these three signs, conjunctival injection, corneal edema, mid-dilated pupil and shallow anterior chamber. Post-laser peripheral hydrotomy it is seen that almost 60% develop increased intraocular pressure, but point to be noted, 40% didn't require any medication, they were cured, and 32% actually required surgical intervention. So if we go into the pathogenesis of proposed primary angle closure glaucoma, it is a genetic predisposition with an anatomically abnormal eye where there is crowding, is because of higher lens volume and smaller cornea, shallow anterior chamber. There is thick peripheral iris plateau configuration, and that can lead to pupillary block or non-pupillary block mechanism, or at some situations is uveal expansion with some living habits, smooth weather, ultimately leading to a narrow entry to the anterior chamber angle, and this PSCG. So fundamentally, angle closure disease is multifactorial. The gold standard for detection of primary angle closure disease is still gonioscopy. The first line intervention is laser peripheral hydrotomy, as it relieves pupillary block and aborts the attack of acute angle closure and reduces the chance of acute attack in primary angle closure suspects and primary angle closure. So this indentation gonioscopy is invaluable as it detects the functional closure, and we need to detect this functional closure. And if we do not detect it, ultimately this light is producing more heat. Can it be reduced?
That spotlight, can we have it off?
Can you put up the spotlight? Dazzle with this. Ultimately, we need to we can get into this hydrotrabecular adhesion like primary anterior synechiae, which can present as either by complete closure, creeping closure, partial closure, or tent like this secondary angle closure like broad-based anterior synechiae, which to be carefully differentiated from these iris processes, which are filiform processes in the periphery and where the angles are actually open. Coming to anterior segment imaging, this UBM particularly is invaluable for structures posterior to the iris pigment epithelium, as sound penetrates the pigment epithelium and the light does not. So it is particularly useful in opaque corneas and congenital glaucomas. So we have a situation sometimes that there is patent laser hydrotomy and intraocular pressure still may be high. So what next? So we need to see by gonioscopy whether the angle is still occludable. If the angle is still occludable, we need to rule out plateau iris either by UBM or by creating a synovial pattern that is seen in this picture. And then we need to see whether intraocular pressure can be medically controlled. If not, the next course of action, we need to see the extent of this peripheral anterior synechiae, and do we have a visually significant cataract or there is increased lens fault. So the rationale of the management will depend on some biological possible facts like appositional closure can cause damage to the trabecular meshwork. The critical threshold of extent of PAS is 180 degree, for some it is 270 degree. The removal of cataract improves angle finding, reduces angular pressure, and in these cases the frequent follow-up is required as the disease is often very fast progressing. So coming to the acute angle closure, the management algorithms, we need to abort the attack medically with a 20% mannitol IV, followed by laser peripheral hydrotomy. Iridoplasty if the cornea is edematous or the iris is extremely boggy, if you are comfortable with it. And AC paracentesis, we can introduce 27 or 30 little tangential to the cornea to restore the angle. It aborts the attack. If it is not aborted, then we can go, and the patient has visually significant cataract, we can go for a primary phacoemulsification. If the anterior synechiae is more than 180, sometimes 270 degree, there is an issue that we can go for filtration procedures. And almost always for the fellow eye, we have to routinely treat with peripheral hydrotomy. The primary angle closure suspect, the management algorithms are that we need to understand the reported prevalence in Asia is around 6.4 to 14.9%. So if we do LPI to all patients, it will result in considerable overtreatment. So it is indicated in the following scenario where there is non-visibility of more than 270 degree posterior meshwork, or with or without blotchy pigmentation, family history of angle closure disease, symptoms suggestive of intermittent angle closure, limited access to treatment follow-up, and so on. Early cataract removal when visually significant, and we need to understand that clear lens extraction cannot be preferred over LPI. And in primary angle closure, if the angle is open following laser PI more than 180 degree match as open angle glaucoma. If it is open less than 180 degree without indentation and IOP controlled on medication, intervene if visually significant cataract. If the indentation gonioscopy shows past less than 180 degree only cataract, go for phaco. And if there is no cataract and there is indentation is more than indentation gonioscopy shows more than 180 degree peripheral anterior with high intraocular pressure, increasing extent of peripheral anterior, we need to do a filtration procedure to control intraocular pressure. And with cataract, we need to do a triple procedure. The similarly in angle closure glaucoma also, it is almost the same steps. And here the IOP getting uncontrolled medication or there is field is progressing with cataract, with only cataract, we can go for cataract extraction, control the intraocular pressure by medication. Uncontrolled, no cataract, go for filtration. With cataract, you can go for a phaco triple procedure. That we need to also remember that in surgical management, in particularly filtration procedure or drainage devices, filtration procedures are more prone for devastating complications. There is high incidence of visual loss. Almost in some literature, it shows almost 6% were blind in 5 years due to choroidal detachments, hypertrophic maculopathy, early onset cataract, and bullous keratopathy. So during surgical procedure, we need to decompress the anterior chamber slowly, tight flap sutures, large peripheral anatomy, delayed suture manipulations, and frequent post-op visits. In cases of 360 degree angle closure where the filtration procedure has failed, we can try GDD in this tube in the sulcus. Goniosynechrolysis might not be useful in long term, as there is a question mark whether it will actually restore the normal TM function, and there is increased chance of cystoid macular edema. The role of cataract surgery is limited. It depends on the size, position, and the thickness of the lens. As you see, if anterior segment OCT picture shows a lens vault like this, or we see a Mount Fuji sign, that is ciliary process we can see through gonioscopy, probably this is a very high lens vault or very high volume cataract. And in these cases, the advantage is they will immediately deepen the AC. There is reduction of angle crowding, relief of the pupillary block, and reduces the likelihood of progressive angle closure. ECP in ACG, there is ciliary ablation under direct visualization. It is controlled and predictable, and we see that in ablation of the ciliary processes additionally widens the anterior chamber angle, especially in eyes with plato iris configuration. Coming to few slides with secondary angle closure glaucoma, there are three mechanisms. Either it's an anterior pulling without pupillary block, posterior pushing without pupillary block, and secondary angle closure with pupillary block. The anterior pulling mechanism is usually an iris or it's a membrane pulled forward to occlude the angle. That is seen usually in neovascular glaucoma, eye syndrome, aniridia, following arterial laser trabeculoplasty. And all the treatment, usually they do not respond to medical management. We need to surgery, either a filtration procedure or a GDT. And posterior pushing without pupillary block, the pathomechanism is lens iris diaphragm is pushed forward through a posterior segment pathology, either by choroidal expansion or vitreous enlargement, etiology mainly malignant glaucoma, iris body cyst, intravitreous silicon-oil or gas, and particularly topiramate-induced UV effusion, that is drug-induced secondary angle closure glaucoma is pretty common nowadays. So the treatment depends on the underlying pathology. It's the tumor irradiation, cystic destruction, silicon-oil gas aspiration, relaxation of the buccal. In general, we need to use IOP-lowering agents, cycloplegia, filtration surgery, cyclotest resection as and when required. With a special mention with secondary pupillary block, and this is often be found that either a traumatic cataract or a dislocated lens in the anterior chamber, pushing forward the angle and structures are not seen in general laxity and all, protruding vitreous phase, gas, silicon-oil in aphakia. The pathomechanism is pupillary block with iris bombay occurring the angle. Treatment is laser peripheral iridotomy following lens extraction, vitrectomy, discontinuing myotics, and laser cyclone lysis. Ciliary block glaucoma needs the special mention. The essential features are simultaneous central and peripheral anterior chamber shallowing, a very high intraocular pressure with patent hysterectomy following either a triple procedure or trabeculectomy, particularly in cases of angle closure glaucoma. The cascade of events are some initiating event following aqueous misdirection with progressive vitreous engorgement and choroidal expansion. The management is vigorous cycloplegia, aqueous suppression, hysterectomy, personal vitrectomy, and vigorous surveillance. Sometimes we need to continue the cycloplegics for years together. So these are my references, and thank you for your kind attention. Thank you.
Thank you, Dr. Dipanshu, for covering angle closer
You
disease.
wonderfully covered the topic, and you were on what normal speed is 1, you were on 1.5 for the benefit of everybody. Thank you.
Thank you.
Now, I don't think it's
Sir, we have-
Cooler we'll discuss later.
Now, I think we can finish it off now.
Yeah, 2-3 minutes of discussion.
Yeah.
Yeah.
So I have a patient, both brother sisters.
Nanophthalmic guy.
No, 52-year brother and 48 years girl, sister. Both are having an PACS. What should I do? Should I do PI for both? Because it's not a family history, it is just a structure. There's no optical damage, nothing.
If you can ensure that they can follow up with you with time wherever you call, like Dr. Rovi Thomas says that it's a yearly once gonioscopy. So I actually tell them to come every 4 to 6 months, because if I tell them to come 4 to 6 months, at least they turn up in a year. Because if I tell 1 year, then probably they come with an acute attack. So it is better to tell them to come every 4 to 6 months to see. And if there is no high intraocular pressure and the disc and field is normal, but it is basically better to do a baseline investigation for this patient. We get a good red-free photograph and perimetry for them.
What does panelist says? Only follow, no PI for such patients.
We talk PACS letter.
Both are PACS, but then both
PACS,
brothers
हाँ,
sisters coming together.
Both.
Similar, both eyes having a same
हाँ, sir.
PACS in
Madam,
both. Like
another-
if you have only one patient PACS, no family history, it's okay. But here both brother sister both are PACS. So should we do PI for such case?
What is the angle? What is the angle like?
It's closed.
It's closed.
Functionally closed.
It's
Opening,
yeah,
no
opening,
signing,
no sign.
No, sorry.
No pigment,
They
nothing.
really do not have a family history of glaucoma.
Yes.
So they are basically PACS, and
Yeah.
we are allowed to observe. If they can't come for a follow-up for 1 or 2 years, I throw in a PA, because it's a relatively innocuous procedure.
Yes,
If
that
they
is what.
can't follow up, they're both individual patients. They do not have a glaucoma family history yet. They only suspect glaucoma family history.
And also look at the age.
Another thing I want to mention, Madam,
48
another
and
thing.
52.
Another thing I wanted to mention in that Velorai study where Dr. Rovi Thomas, he said that if the patient presenting with bilateral PACS in an Asian eye, he sometimes prefers to do PI.
That is why,
Bilateral
because
PACS in Asian eyes,
both
yeah.
sister and brother coming together, 48, 52 years, PACS.
I don't know. It depends on the surgeon or on the clinician. Opinions can differ. We can also do a axial length and a biometry for the patient. See how much is the axial length, how much is it contributed by the lens. And not that we are going to do a lens removal, but that would also guide you. But and it also, like Dr. Thomas said, depends on follow-up. If in doubt and if patient is willing, do the PI. What I feel is it's more difficult to convince patients who are healthy and walk in without any problem to convince them for a LPI rather than to tell them to come and for a walk. What
I
does
did
your panel feel?
I did a follow-up for 2 years. They are not doing any progression.
The actually problem is that if we tell the patient that you have a propensity to develop glaucoma, then obviously they will tell, sir, please, madam, do whatever you want to do.
You do it, yes. Because I did a follow-up for 2 years and now they both are saying it's better to do a PI if we have to come for a follow-up.
Exactly.
again.
I throw one more spanner into it. If we actually gonioscope every patient who walks into our OP, around 5 to 10% will find PACS.
Yes.
So if you look at the entire year's population of PACS, we will have no time to see the OP, we will only have time to do the PA.
They have one systemic antihypertensive so that is going.
If the mother who has lost vision or if a brother has got something, it adds to the risk factor.
Somebody has an overt disease.
Yeah.
If there's any synechiae, yes. Any synechiae are good.
So what was your indication to put them down as PACS again? Was it-
Because they came for a routine eye checkup. The mother has ARMD. So they come for the ARMD injections every time for the mother. And then I saw both brother sister.
They had shallow
The one Harix was very narrow. And that is why I subjected them to full.
Regular irradiation.
No, yeah. But
Again, it is better to do.
Yes, then definitely we are going to. That's an indication for PSCs. But
If there
because
are
these
any-
both systems are together, so you know it's probably something familial going on.
Hypertension different.
I would be more careful in seeing the mother's eye as well.
So mother definitely doesn't have a glaucoma, though she's pseudophakic ARMD.
Pseudophakic is.
Yes.
But I think here it is because you need to dilate, so that is an indication that you should go ahead with the PI. But I agree with Dr. Thomas that if the patient can come and follow up, still maybe wait.
Yes. I've been seeing them from past 2 years, but then every time they come and say it's better, you are injecting to the mother, why not do a PI for us?
Any other questions? Yeah. We'll call in the next.
Thank you so much, sir. Now we move on to second talk, evaluation of the case of pediatric glaucoma by Dr. Neetu Mohan.
I hope the temperature goes down a bit as I go. Yeah, it's better now.
Is that is? That is what is that?
Here it's cooler. Okay, so my topic for the day is evaluation of a case of pediatric glaucoma. So how does a case of slides are not moving? Yeah. So pediatric glaucoma differs from adult glaucoma in response to a high intraocular pressure. That is, till 4 years of age, due to the elasticity of the globe, there is an increase in axial length, corneal diameter, myopia, and also reversible cupping in a child. Defining childhood glaucoma, it is in an individual below 18 years of age, the presence of any two or more of the following. That is an IOP of more than 21 millimeters of mercury, optic disc changes suggestive of glaucoma, increase in corneal diameter or abstract, progressive myopia documented by an increase in axial length or retinoscopy changes, or a reproducible visual field defect. The presence of at least one of these would become a diagnosis of a glaucoma suspect. That is an IOP of more than 21 millimeters of mercury on 2 different occasions, a suspicious optic disc or a visual field, increase in corneal diameter or axial length with normal intraocular pressures. The incidence of congenital glaucoma, though it is estimated to be about 1 in 10,000, it is much higher in populations like ours where consanguineous marriages are more common. It's important to rule out conditions that mimic glaucoma, and also the most importantly to counsel parents regarding the need for lifelong follow-up, discuss the surgical options, need for multiple surgeries, and to be sensitive to the needs of the parents. The classic triad of congenital glaucoma, as we know, consists of photophobia, blepharospasm, and watering. History would include age of onset of symptoms, gestational history, family history, general pediatric history for anesthetic fitness, as well as considering other associated syndromes, and ocular history. Examination would consist of all these steps. We'll go through them one by one. And it's important to remember that examination under anesthesia is not entirely benign, and multiple exposures can lead to long-term neurocognitive changes. And it is to be considered only when the data acquired will provide a timely diagnosis and also allow surgical intervention, hopefully in the same setting, or it will at least provide follow-up data that will significantly influence the clinical decision making. So as a rule, all inhalational anesthetics lower the intraocular pressure, and the moment the child is intubated, there is an immediate rise in the intraocular pressure. Ketamine causes a transient rise in intraocular pressure. Chloral hydrate and benzodiazepines, there is no change. So be ready to acquire the intraocular pressure as soon as the child stops moving. It is the first test done during an examination under anesthesia. And if the anesthetist allows, it's also a good idea to consider intraocular pressure measurement immediately after pre-medication before the child is induced. So we have this tray ready before an EUA. We insist on this list. We have this list in the OT, and the entire tray is kept ready by the OT sister before the child is induced. And general visual behavior and visual acuity earlier assessed in the clinic should include photophobia, squint, nystagmus, age-appropriate visual acuity. Intraocular pressure can be measured in a bigger child with golden applanation tonometer or Perkins and rebound tonometer during EUA. We do both Perkins and rebound tonometer to have additional values on follow-up. And IOP is the least accurate parameter, and diagnosis is never to be based on an elevated intraocular pressure alone. Anterior segment can be examined with handheld slit lamp or with the operating microscope itself. And this gives a lot of clue regarding the type of glaucoma, primary, secondary, and also has implications on prognosis and genetic implications. Gonioscopy with a direct or indirect lens, and in primary congenital glaucoma, you expect the iris insertion to be high directly into the trabecular meshwork, and a pale amorphous tissue may be seen in the angle as well. Corneal diameter measured by calipers, both horizontal and vertical values, again for more values to have for follow-up. More significant in children less than 3 years of age. And as we know, more than 11 millimeter in a newborn, more than 12 in an infant, and 13 at any age is considered abnormal. Central corneal thickness, good to document, though the relevance in children is still uncertain, and CCT corrected IOP is not as reliable an indicator as in adults, but it is to be documented in every child during EUA. Fundus evaluation to be documented by REDCam or by detailed drawing, since this is the most sensitive parameter for diagnosis and progression. It's not influenced by anesthesia or by growth. Axial length preferably by A scan, if not possible at least by B scan. Repeat every 3 to 4 months, and the steepest growth, as we know, is in the first year. And this plotted, the growth of the change in the axial length plotted against the age in months, gives us some indication regarding the growth of the eye, and any variation from normal will be quickly detected if it is plotted on a graph as this. Refraction can be done in the clinic or during EUA, and progressive myopia suggests inadequate IOP control. It is critical to address emmetropia, since amblyopia is the commonest cause of poor vision in spite of good IOP control. Visual fields, around 7 to 10 years, some children may be ready to attempt a visual field. It depends on the developmental milestones, the dexterity of the child, and once the child is able to cooperate, you can try visual fields. Ultrasound B scan may be needed for posterior segment evaluation in some patients, and every unilateral glaucoma should be considered secondary unless proved otherwise, and a thorough evaluation should be done to rule out any possible causes for a secondary glaucoma. UBM may be needed in some eyes before surgery to consider if there are any corneolentricular adhesions and to assess the anterior chamber angle. Disc imaging also may be good to have as data for follow-up. The role of genetic evaluation is still not very clear in congenital glaucoma, and the cost-benefit ratio is not yet well established. To summarize, use every opportunity to examine the child, whether it is in the clinic when the child is sleeping or by feeding, and consider EUA only when the data acquired will facilitate clinical decision making or when you are planning a surgery, and go through the EUA step by step and document all the data for serial follow-up. Thank you.
Thank you, Dr. Pitu, for compilation so fast, and you have finished 1 minute prior.
One thing which I'd like to add is that I always prefer to do a no-touch test prior to doing a touch test. So so that ensures that we and also keep everything ready and maintain a Excel sheet kind of a thing, so that we can properly see as to how the things are proceeding.
Even in the clinic, the technique that you said is better. We finish all the other non-contact procedures and finally we try to force the child for a direct ophthalmoscope. And many times we get away with just when the child is sleeping or feeding or something.
So what is the opinion of the house, the triad, which is actually so often written in the books? How often do you see the triad?
Only see it regularly.
You see the triad. Any other opinions? No. What I'm saying is, they say na epipora, photophobia.
Yeah, that's what I'm saying. The epipora and photophobia, like most of the time, they don't have any symptoms, they just come to the eyes.
I would agree with Ganesh, because when I was in Bangalore, we used to see it very regularly. But the around 200 population, it's not that bad that they're not born with a white cornea. They usually pick up as a large cornea, and at that point it's we get the patient. So there's a lot of variations. And in Tamil Nadu, we used to have those born with white corneas which are actually sitting outside the eye, literally, and outside the face, literally. Those we're not seeing in Joanna.
And also it's more of the like when I was in Cochin here at Amrita, So there were more of those syndromic children with tetralogy of Fallot or something, which were referred to us as rather than a primary congenital, and they would very often end up having these things. But I did not come across so many people who were complaining of the watering and everything before so I'll just find. Justine, what is yours? So my question is, you don't see the symptoms, and you were saying you see
maybe 1 in 2 in a year, maybe 1 in a year.
Different aspects of NTG management. So the first one is a case of a 70-year-old gentleman who presented for a routine eye screening with the intraocular pressure of 16 and 18 millimeters of mercury in the right and the left eye, an open angle by gonioscopy. The right eye disc was about 0.8 with bipolar thinning, and the left was again 0.8 bipolar with more of inferior rim changes. The perimetry showed corresponding biarcuate defects and of the right eye, and the left eye showed superior arcuate changes. So investigating further, they had average corneal thickness. The diagonal variation test did not go beyond 20. So with this, we made a provisional diagnosis of normotensive glaucoma in both the eyes and started the patient on prostaglandin analogs. Revisiting the NTG history, he gave a positive family history of glaucoma. He was a diabetic and also a history of occasional micturition syncope. So in this slide, we kind of assess the vascular factors. The ocular perfusion pressure was assessed in different postures, and we found that it was significantly less in the right eye, fluctuating between 40 and 46 millimeters of mercury, in the left eye between 39 and 45 millimeters of mercury. So various studies, landmark studies like Rotterdam and Barbados have highlighted the significance of ocular perfusion pressure in open angle glaucoma. To throw further light into the vascular factor, we also did a color Doppler imaging. We found that the resistive index was found to be significantly higher in both the right and the left eye, going between 0.69 to 0.8 in the right eye and between 0.75 and 0.79 in the left eye, which kind of concurred with the Western literature, where they showed an association of NTG with a resistive index of about 0.8. So the vascular pathomechanism is well established as far as NTG is concerned. Following this patient up in December 2022, the right eye was fairly stable on 3 AGM, and the left eye, though the trend looked fairly stable, there was progression in the event analysis, which was also seen in the 10-2. We advised trabeclectomy and cataract extraction, and 4 months since he's been stable. So this is a regular NTG presentation. So going on to the second case is that of a 34-year-old gentleman who presented with a low baseline intraocular pressure of only about 12 millimeters of mercury, and what was striking was the asymmetry in the cup disc ratio. So the left eye, there was a superior notch, and the only positive history was dyslipidemia. So considering the asymmetry in the glaucoma presentation and the low baseline intraocular pressure, we also got a neuroimaging done, which was fairly normal. This was the right eye perimetry. The left eye showed rapid progression. This was the picture 2 years later. So because of the history of dyslipidemia, we did a carotid Doppler, which showed a circumferential plaque of the left carotid artery bifurcation. Case 3 is a symmetrical cupping with inferior rim changes. So she also had a baseline intraocular pressure of only 10 millimeters of mercury. So again here, what is striking is a symmetry in both the structural and the functional test. So the question, and she was absolutely symptom-free, though the central field was markedly involved, there was no visual symptoms whatsoever. In the light of the above said findings, the question is whether we were dealing with the anomalous disc. So talking about case 4, this was a recently seen patient who was treated as MTG outside. However, there was a marked asymmetry between the disc parameters and the visual field changes. Got 10-2 done for this patient, and what we see is a ring scotoma. So while asked for a positive history, he did say he had difficulty in dark adaptation, and he was referred for a retinal clinic opinion where he showed reduced scotopic responses in both the eyes, and he was concluded to have cone rod dystrophy. So the other important differential to consider would be neurological causes, where the cue would be paramordan cupping, fields respecting the vertical meridian, and the disc not correlating with the fields. Other add-ons to NTG diagnostic toolkit would be a detailed sleep apnea workup, OCTA, neuroimaging, coagulation profile, and nutritional deficiency assessment. The stop band clinical assessment score can be done to assess the severity of OSA. Again, the role of OSA in NTG has been well proven. So that my take-home message is detailed history taking and extensive workup is required to rule out IOP independent factors and other differential diagnosis. However, we do continue to manage them like any other open angle glaucoma, where IOP is still relevant as proven by CN-GTS study. NTG also remains an enigma. We must, much to be known and researched as far as NTG is concerned. Thank you.
Thank you, Nagalakshmi, for wonderful collections of NTG. You are 34 years patient. Did you treat that patient? Cause was carotid.
Yes, ma'am. We did put him on anti-glaucoma medication as well, because it was riskier to wait with such a rapid rate of progression. Though we did address that aspect by starting him on antiplatelets as well.
That is, it's good to treat at 34 years because the age was very important.
Anything about the CSF pressure?
Not really, sir. We didn't do it.
Just one thing that I would like to comment about the OSA part, because we just published an article, it just come out in Journal of Glaucoma. So one needs to be very careful and need to rule out OSA, because sometimes you have some patients, your target pressures are not being achieved with your adequate medication, and those are the patients you should look at the ocular perfusion pressures and the OSA, because we found even with the normal subset around 90 patients on OSA, the severe cases of OSA, they had pressures in the range of 17, 18, 19 millimeters of mercury, and RNFLs were in the range of around 80 microns, which is actually on the thinner side. So you need to be very careful about OSA also.
In your patients, once you titrated the OSA, did the intraocular pressure reduce? Once you do the CPAP, what I have noticed is if you put them on CPAP, see them about 2 weeks, 4 weeks later, the intraocular pressure starts coming down.
So again, there are two views on that. Some people say that using CPAP, the IOP might go down. There is another thought which says using CPAP, the IOP may actually go up. So it's still controversial. During this one, you take some.
You did CPAP. You use the CPAP.
So we did. नहीं CPAP के बाद ही लेगा. CPAP के बाद वो नहीं लेगा.
That will be the next paper. We also published one on again. Yeah.
बट उसमें कहते हैं कि कुछ कहते हैं कि बढ़ भी जाता है, कुछ कहते हैं कम हो जाता है. So still
See, OSA patient, whether we should treat or not.
The patient I am talking about had got triple combined procedure in both the eyes, one tube implant, and on 3 medication. After titration with CPAP, pressure was hovering around 20, 19, 20. After titrating, it became like 10, 11, 12. So I was shocked. He was also very happy. I gave him ambulatory BP monitoring, this, that, everything. He said everything's fine. Just did CPAP, did titration. His AHI level improved. His IOP dropped. I was able to reduce one by one medication I have to wean off. They don't have to use it every day. He uses it only 3 times a week. Every day it's very cumbersome.
People who do use the CPAP become very used to it, and they won't even go. They won't ever go even one day without it. So if it can help somebody, I think we just need to follow up with these patients and see as to how they do. नहीं होती. आजकल they have very good masks which are just around the thing and it doesn't.
Exactly. It's very.
I live with a person who does. My husband doesn't.
And even after use it, it doesn't hamper. It doesn't come with the low or anything.
There's more incidence of cardiac events, so if they use it, it is always better.
And I had a question, yes, Ghana, what would be your first line of treatment for NTG? Because for your patient, the first case you had put the patient on
prostaglandin. So the first patient, the patient had a high pressure. I mean, his pressures were in the higher teens. and he already had a family history, one more risk factor. So I thought the target pressure should be at least 30% lesser. In maybe a suspect kind of case or early glaucoma, maybe brimonidine might have been a better choice.
Another thing, you talked of the resistive index.
Yes, ma'am.
And amongst the different patients, if you go back to that slide,
Yes, ma'am.
it was the ophthalmic artery which they had it higher.
Yes,
the others were not. But
yes.
actually, they say it's the it's the lateral ones and not even the CRA which is important.
Yes, ma'am.
So whenever we do it for 4 vessels. The ophthalmic artery, the central artery, and the lateral and medial arteries.
Yeah, that particular case actually, because there was a history of syncope, we wanted to evaluate on the vascular aspect as well. So as you rightly pointed out, it was more of the ophthalmic artery which showed a higher side of
which does not actually have so much of a role
clinical
to play in
significance.
the
Yes.
ocular profession.
Thank you.
Thank you so much. Now we move on to another case presentation by Dr. Sonika Porwal.
We had a 28 young lady presented to our clinic with ocular discomfort. There was no other significant history. She had a family history of glaucoma. The rest of the ocular examinations were normal. The main important things were the IOP was 36 millimeters of mercury and 32 millimeters of mercury in the right and the left eye. And the fundus was normal. This was around 0.3 with a healthy rim. Glaucoma workup was normal. Diagnosis of ocular hypertension was made, very early GOI. So we started the treatment, started with anti-glaucoma medications. One glaucoma medication was good enough. 1 month the pressures came down to 18. After 3 months follow-up, the pressure started going up again around 28. After 1 month, adding one more glaucoma medication, it was 24. Adding one more, it was 20. So we thought something was not fitting into the puzzle. Something was wrong. So we started taking history again if she was using any other steroid by any means. She was using a fairness cream for her marks, okay, and then we found out what were the contents. It had mometasone and we had to stop it. So we decided to stop it and see. And initially we had her on AGM and then off this cream, and then off AGM and off cream the pressures came down to normal. It was a 1-year follow-up and she's doing well. So the pearl is young patients with ocular hypertension. She had a family history of glaucoma in the grandmother. So the glaucoma history strikes us, but such patients are steroid responders. Ask for history of cutaneous creams. They usually use creams for marks which have steroids. Second case was a 50-year-old lady, came to our clinic with complaints of difficulty in near vision. Ocular examination was okay with the IOP of 25 millimeters of mercury and 26 in the right and the left eye respectively. Open angles. The disc finding was around 0.5 with the inferior equal to superior in the right eye and 0.6 with the IR notch in the left eye. Pachymetry was normal. Perimetry showed, though unreliable, it was a borderline GHT in the right eye with parietal scotomas and the left eye showed a superior arcuate. OCT showed superior thinning in the left eye. The twist in the plot was that she was using an antibiotic dexamethasone combination eye drops for 12 months. She was off the drops for 3 months. So she didn't feel that it was an important history, but our diagnosis of query steroid-induced glaucoma, query POAG was made. On AGM, her pressures were normal. We started the AGM for 1 year. Thought of stopping the steroids and seeing if the steroids were off for around now 1.5 years. Stop the AGM and see what she responds. She responded well. Without AGM, the pressures were normal. So the pearl here is steroid effect may last for around 6 months to 18 months of stopping the steroids. So try stopping the AGM and see if she's normal. If IOP is coming back, the disc and the perimeter remains the same. Diagnosis dilemma comes when the patient comes to you for the first time with a normal IOP with a disc suspect. Ask history of steroid use in the past. Look for any other features of NTG or document progression before coming to any diagnosis and starting the patient on lifelong treatment. Okay, this factor. Discuss.
Thank you, Dr. Sonika.
You have to really dig for steroid history. I recently had a cardiothoracic surgeon coming to me with intermittent blurring with halos, and pressures of 50s. Dig. He had some itch on his hand, so he asked the dermatologist friend. He got mometasone again. He got his medical rep friend to give him loads of it. So it doesn't cost him anything. So every day half a tube was going on to his palms as cold cream.
Otherwise, it's difficult for you to do surgeries.
Yeah, that's what he attributed it to glove allergy and things like that. He found it very easy to continue his work.
Patients are Ayurvedic creams. They say patients are diabetic of the Ayurvedic creams. They would contain steroids.
And we know we are finding Sanskrit.
Here in Kerala, you have something called Pfizer cream. Pfizer cream, there's the natural beauty cream, so Ayurveda cream, I don't know. And they all come with, raised IOP.
Some Sanskrit names we
Yeah.
make out what
Very
And
difficult.
another, I think we also need to sensitize all our other physicians who give steroids for a longer course. Like patients, like the nephrologists, when most of the patients of renal transplant are always on maintenance steroids. Yeah, so the other physicians need to be sensitized that this
And
is
also-
an entity and they only relate it to cataract. And they'll send you the referral also. Please check if there is cataract or not. Get anything else.
We recently had a patient who was using a heparin cream and she was bleeding from the trap ostium site. So every 15 days she'll come with a hyphema. We were also wondering why it is happening. Then we dug deeper, we found that she's using some heparin cream for acne.
That just tells us that the long old age-old dictum of take a good history stands true.
Actually, she made a statement relevant to the previous topic.
NTG.
So,
So,
NTG, we should not diagnose without actually documenting progress. Till then, you have to be suspect.
Thank you so much. Now we move on to our last case by Dr. Dilip Lalwani, and he will be presenting on lens-induced glaucoma.
Thanks, Scientific Committee and All India Society. So, lens-induced glaucoma. My case is 70-year male presenting with intense pain and sudden deletion of vision with high IOP and mild medically hypertensive, diabetic and heart disease. And when we see the slit lamp, it has mild congestion with corneal microcystic edema with shiny deposits and fat like capsule is there. And when we do V scan to confirm that diagnosis is there, so we found that hyper-reflective echoes in the V scan reports. And so we did here provisional diagnosis phacolytic glaucoma and started medically management with the mannitol. And after controlling the mannitol and topical beta blockers and steroid, we started and we diagnosed that this is a etiogenesis of this is lens, so better to remove lens. And we planned a phaco surgery with IOL implantation, and by dyeing the blue rats capsule, we did a perform capsulotomy, and here lens is a main role of etiogenesis in this phacolytic glaucoma. So gradually we emulsified the lens and implanted a IOL. And one of the main thing is that appearance of this case is very early, 1 or 2 days. So it will depend if you plan only cataract or cataract with the trap surgery or any other angle surgery. So after performing the lens implantation, usually this is a 3-piece implantation of the IOL. So if any case is presenting with the 7 days or 10 days period, then definitely you will find a synechies or so here after the performing surgery, I will do some lens visualization whether there is an angle blood there is or any lens pigments, lens protein is deposits or not, or any fibrosis is not, there is not any fibrosis or synechias. So we after performing this surgery, post-operative results are good and some slight post-operative edema is there and IOP is in the 15 or 16. So here we can take home messages that it is a triad of acute pain, congestion and high IOP. So we have to see this type of cases, and common cause of phakomorphic phacolytic is very rare. So general awareness to the doctors should be there, and patient is also aware that once you feel pain or high IOP or sudden intense red eye, then it is you should come first. So public awareness and early detection is important, and early cataract surgery aids in visual recovery and IOP control. Thank you.
Thank you, Dr. Dilip.
Spatula, I am using for last one, sir. Dialect, some site of dialect. Circular, half circular. That time it is very important to lift the lens
And you said a very nice point about doing a gonioscopy at the end of the surgery to decide whether any further management for the angle is required or not. Because it depends on the duration of how long the lens-induced glaucoma had been sitting. If it is more than 7 days, it's more likely that it has converted to a synechial angle.
Now, currently, I think most of the people wait and see how things.
I agree.
Is it actually necessary to do any transfer also?
You can. But if you are, since we now have the availability in more OTs of Swan and Jacob than before, it's a good opportunity to use it and see if it is.
No, how is it going to change your management? If you find synechial or you don't find synechial?
You can decide to do a phacogram.
Synechial at that moment, sir.
You want to do GSM, you want to do gonioscopy at the same.
That probably can not a trap.
Yeah, trap because you have to do it before.
Other thing is phacolytics rarely get synechial. Phacomorphics.
Yeah, it's only
synechial. It's a continuum with the chronic angle course situation.
Sir, if in these circumstances, if you use the lens and you find the synechial also, then inflate in that condition, perhaps better for what you are. Decent traveling is going to entangle in other
It depends on the kind of population you are dealing with. If it's somebody who's come from the periphery and is here only for this surgery and not going to come back to you, your approach will be different.
If you are that suspicious, then you better do a trap.
Better. If it doesn't filter in the immediate time, it will just fail. No harm done.
For a phakomorphic glaucoma, I think the other lens should go appear. Like,
Yeah, and do a gonioscopy and take a shot.
like it's there, usually the other lens should appear.
That's very nice.
Once again, going back to a old publication from AIOC, the highest risk factor for both phacomorphic and phacolytic then was other eye being swollen. If one eye has got good vision, second eye is kept till it becomes a problem. And it's still true. Phacolytic and phacomorphics that we see, the other eye is swollen.
If that other eye is faking, then you have to really watch that.
Get it out fast. Encourage the fellow to get it out fast.
I think the next session, if people have come to get us out fast. Thank you so much.
I request all of you to come for a photograph and
അപ്പോൾ ഞാൻ മാനുവലിൽ ഇട്ടേക്കണം ഇവിടെ സൂമ ഇങ്ങനെ ആണെങ്കിൽ സൂമാവും എന്നിട്ട്